So our first speaker is Dr. Alyssa Lucas. Dr. Lucas is a staff neuro-oncologist at the Cleveland Clinic and is an assistant professor of neurology through the Cleveland Clinic Linear College of Medicine, as well as an associate program director of the Neuro-oncology Fellowship Program. She has a special interest in neurofibromatosis and schwannomatosis, leptomeningeal disease, and a passion for promoting the well-rounded medical education of trainees. Dr. Lucas, thank you.
Hi, thank you. My name's Alyssa Lucas. Thank you for the nice introduction, and honestly, thank you so much for giving me the opportunity to be able to speak today. I have no personal disclosures or any conflicts of interest to disclose. And where we're kind of going to be going with this talk as a primer for the rest of the day is kind of our recent past, our present, and how we can use those to kind of shape the future and the ideals of where the field should be headed. So in order to kind of dive into targeted treatments and a lot of the progress that's been made in therapeutic options for NF1 and NF2, we have to very briefly touch on kind of the underlying pathways that lead to kind of the tumor formation to begin with. So essentially, we have a pathway called the RAS-MEK pathway, and when this pathway is working normally, it leads to kind of increased cell turnover, growth of cells, and kind of promotes the cell's survival. So typically, there's a protein called neurofibromin, and it's kind of the brakes on this whole pathway. And so this can kind of regulate things, keep things from going out of control in terms of cell growth. When there is mutation in the NF1 gene, this leads to a loss of function of this protein neurofibromin. So essentially, we've kind of lost the brake pedals on this pathway, and everything is very much amplified. We've got kind of pedal to the metal type of situation with the gas, and this leads to kind of an overgrowth, too many cells dividing, and kind of promotes the survival of these cells. And this is what leads to the kind of clinical manifestations that we see in neurofibromatosis type 1. Certainly the neurofibromas that are characteristic, but other manifestations as well. In order to kind of understand where some of the drug development ideas are coming from, it's important to kind of keep this pathway framework in mind, because the thought being that since we don't have our own brake mechanism with the neurofibromin protein, is there a way that we could kind of supply our own brakes to kind of externally stop this pathway from being revved up and out of control? Also, just to briefly mention, because I feel this will come up multiple times today as well, the kind of different phases of a clinical trial and how things like drugs and interventions kind of move through this. So, of course, we start with our preclinical data, things that are discovered kind of more in the lab setting with models, cell lines, that kind of thing. This kind of leads to the creation of a phase 1 study, which its goal is primarily to take, a smaller group of participants and determine the safety of, said medication. This leads to kind of the creation of a phase 2 trial, which is more participants, certainly still evaluating safety of an intervention, but then also kind of trying to get some initial thoughts on the efficacy. Does this drug even work? And oftentimes, this leads to a much bigger phase 3 clinical trial where not only are we trying to kind of really hammer down on the safety, but also figure out, is this intervention effective? Sometimes that is compared to something like a placebo medication or whatever the standard treatment is for that disease. It's often the phase 3 trials that lead to the FDA approval of something like a medication, but as we'll see, sometimes we have enough data from the phase 2 information in order to do so. So, a lot of the recent kind of therapeutic advancements have been in the realm of treating symptomatic, inoperable, plexiform neurofibromas. So, I know, there's been 4 trials essentially in the past 6 or so years that have been discussed, I'm sure, at other presentations and conferences, but we'll do kind of a quick summary here. So if we're thinking back to our RAS-MEK pathway, we are kind of using a drug class called MEK inhibitors to apply the external brakes on the MEK to kind of decrease the downstream effects of that pathway that's overactive. So the initial phase 2 trial of selumetinib, one of the MEK inhibitors, aka Koselugo, in children was in 2020. I'll also mention that all 4 of these studies used kind of similar endpoints to try and determine if the drug is effective or not. And a lot of the kind of primary endpoint involves the decrease in tumor size on something like an MRI scan. So specifically, a decrease in the volume of the tumor overall by 20% or more is considered a response. So the SPRINT phase 2 trial of selumetinib in children, and then later the phase 2 trial utilizing selumetinib in adults in 2025, had very similar, response rates in terms of using that metric, the decrease in tumor size, with response rates in the 60% range. These led to the phase 3 study of selumetinib in adults called COMET. Again, with a very similar kind of structure and endpoints. There was additionally in 2025 a phase 2 clinical trial called RENEW, evaluating a different MEK inhibitor, mirdametinib or gomekli, and this also demonstrated benefit in terms of the objective response rate on the size of the tumor. Importantly, though, all 4 of these trials not only looked at kind of the numerical, volumes of the tumor, which of course may or may not kind of correlate with a patient's experience and symptoms, but also started to kind of implement measures of quality of life, pain control, symptom management, which arguably kind of are more translatable to the patient experience and more relevant, when a patient is trying to decide, if a medication is, worth the risk for the benefits. In addition, there are ideas of combining 2 medications that kind of target 2 different locations on that RAS-MEK pathway to see if, in combination, 2 separate brake mechanisms are more effective than one. And also, very importantly, of course, there's a lot of work being done in the MEK inhibitor sphere, but it's also important to kind of think of other mechanisms. How can we approach this outside of the RAS-MEK pathway? Especially important if someone has not had a good response or has had side effects to a MEK inhibitor, to kind of have something else in the toolbox to reach for that might have a totally different side effect profile. Here's just a graph from the RENEW study in 2025, highlighting in adults the best percentage of decrease and increase of tumor size in plexiform neurofibroma. I just put that up there to kind of show what a wide array of responses there are in the patients who were included in this study. Cutaneous neurofibromas, the treatment of them remains quite an unmet need in terms of, systemic drugs. There are certainly kind of more procedural aspects of treatment of cutaneous neurofibromas that I'm sure will be elaborated more on in kind of later discussions. But there are therapies under investigation for the treatment of cutaneous rather than plexiform neurofibromas. There's an ongoing study evaluating the mirdametinib, or gomekli, the same MEK inhibitor that we had discussed for plexiforms, to see if this could also be effective in decreasing burden of cutaneous neurofibromas. There's also interest in trying to determine how we can deliver a drug such as a MEK inhibitor directly to the skin to limit kind of some of those systemic side effects and decrease the amount of drug that's actually kind of absorbed into the system that causes a lot of the other kind of side effects we associate with MEK inhibitor therapy. And again, just kind of to give examples of trying to think outside the box and come up with different or novel mechanisms for ways that we can help identify treatments for cutaneous neurofibromas for our patients. And certainly, Excuse me. Certainly, there are other manifestations of NF1 that are being evaluated in terms of new treatments, malignant peripheral nerve sheath tumors, gliomas, kind of the whole sphere. But now we'll kind of move on to talking about NF2-related schwannomatosis. It's a very similar kind of underlying pathway in NF2 as compared to NF1. So we still have this kind of constellation of complicated pathways that ultimately lead to increase in cells and kind of the cells glomming onto each other and making tumors. Instead of the neurofibromin protein like we had in NF1, we have the myelin protein, which is the brake system on this very kind of complex interplay of these different pathways. So NF2 mutation ultimately leads to a non-functioning brake pedal for the myelin protein and kind of has these downstream effects of increased cell growth, proliferation, and adhesion to one another. This is especially seen in specific types of cells, which can explain kind of the different tumor types that we see in NF2-related schwannomatosis, such as the schwannomas, meningiomas, and also ependymomas. There are currently no FDA-approved systemic treatments for NF2-related schwannomatosis, but we have been, evaluating drugs that are used for other conditions, kind of repurposing, rebranding them to try and determine if they're effective in NF2-related schwannomatosis. I did also want to just mention the Intuit NF2 trial, one of the arms of which was published in 2024. It's just kind of a novel clinical trial outline and structure where folks were trying to look at could one single drug therapy be effective in treating multiple of the different tumor types that we see in NF2-related schwannomatosis, including schwannomas, vestibular or otherwise, meningiomas, or ependymomas. Honestly, I put this in because it's a very aesthetically pleasing graph and just to kind of highlight the variety of different tumor types that were evaluated in the brigatinib kind of basket of this clinical trial. In addition, there have been advances in identifying other kind of molecular underpinnings for schwannomatoses that are inherited outside of NF2-related schwannomatosis, including LZTR1, SMARCB1, ERB2-related schwannomatoses. And as we get, expanded access and use to genetic testing and inclusion of these types of genes in inherited cancer panels, then we are kind of identifying more and more of folks with these mutations. And of course, it's helpful to kind of give a name and a label to a kind of underlying diagnosis for schwannomatosis. And the ideal kind of scenario would be to use this information to try and guide kind of precision targeted therapies for these entities in the future. And then, I feel that a lot of these are going to be kind of themes throughout the day for multiple presenters and a lot of different presentations, but just kind of as like a teaser for what is to come. The future of the kind of diagnosis and management of NF1 and NF2 will certainly kind of have multiple different focuses. So one, can we kind of come up with different biomarkers, different models to try and predict the behavior of some of the tumors associated with these conditions? Are there ways that we can use things like MRI imaging to try and predict, for example, something like a plexiform neurofibroma that has high-risk features to transform into something malignant, such as a malignant peripheral nerve sheath tumors? Also having kind of structured consensus guidelines from experts in the field in order to kind of have a more consistent framework to work with in terms of a lot of the monitoring and surveillance that goes into the care of NF1 and NF2 patients in particular. A big area of interest, including here at the Cleveland Clinic, is also how to make the seamless transition from pediatric subspecialty care to adult subspecialty care. It certainly can be a jarring transition. And so how do we kind of ease that? How do we give warm handoffs, improve communication to kind of take the burden off of the patients and their families? And then I feel that there has also been kind of more of a paradigm shift in terms of how do we even kind of think about these diseases, what are the concepts, and instead of kind of being reactive and treating symptoms kind of as they come, kind of thinking about it more as a chronic disease that we need long-term control of and longer-term solutions. We talked about how quality of life measures being integrated into clinical trials is certainly, a helpful, more translatable kind of marker to the patient experience, and certainly advocacy. So us as providers being able to advocate for our patients, advocate for the things that we need in order to take great care of our patients, and our patients and families for advocating for one another. And this is especially true in terms of access to care and NF specialty centers. So overall, the future in terms of the ideals for management of neurofibromatosis is really multidisciplinary, lifelong, collaborative, and comprehensive. The key takeaways are that there have been recent advances, certainly in the management of neurofibromatosis and schwannomatosis, and more importantly, there are more to come. And that these conditions really truly require multidisciplinary care with collaboration among all providers of different disciplines. And progress really starts with taking new ideas, thinking outside the box, challenging the status quo and kind of what has previously been accepted to try and find new ways to improve care for our patients. And thank you so much for giving me the opportunity to speak today.